So, Dr. Anna Groysman, she completed her endocrinology fellowship at Harvard Medical School, training at Beth Israel Medical Center, and also Joslin Diabetes Center. She's our distinguished speaker today. She's currently a faculty physician at University of Pennsylvania in Bucks County. Dr. Groysman is a Menopause Society certified practitioner. She's especially passionate about caring for women during perimenopause and menopause, a field where access to knowledge care remains limited. So, it's about you.
Thank you. So I'm honored to give this presentation today because when I was in fellowship, we did not learn about menopause. It was not on the boards. And sorry, did I hear somebody? Can you hear me?
Yeah. Yeah.
Okay,
Yeah,
okay.
we
I
hear
just thought somebody was saying something. So we were not taught about menopause, and what I have found is that we need to talk about it because ever since the Women's Health Initiative, which scared many of people from prescribing for reasonable concerns, we now have reinterpretation of data. We have new treatment formulations, and we're better able to select women who would be better candidates for treatment. So, with that, I think it is important for us to now learn about it and provide the care. And I just, before we start and dig into the data, I want to, for just 1 minute, take you into the life of a woman in perimenopause. Imagine you are in the hospital taking care of patients. You come home, you go to bed, and at 3 o'clock in the morning, you wake up, eyes wide open, and you do not know why you're up. You're exhausted, but you cannot fall back asleep. You have to go back to work. I don't know, 6 a.m. or 7 a.m., whatever time you're back, and you need your brain to think. You need to make clinical decisions that are very important. But imagine this lack of sleep for days on end, for months. How does that affect your cognitive function, your decision making? Uh, you're finding that you have word finding difficulties. You're not able to put things together like you used to, and you're a very sharp, smart doctor. You are finding that you're having hot flashes to the point that sweat is dripping through your shirt. So when you're in front of colleagues or patients, it becomes embarrassing. So you need to take a change of shirt. Uh, you're finding that you're more moody and it's affecting your professional and personal life. And if you are of female sex, you might have severe vaginal dryness where you're very uncomfortable. You're finding that you're having more urinary tract infections, and it's just painful to have sex, which is affecting your marriage. So this state, a normal progression in a woman's life, can turn one from being a highly functional individual to really making it very difficult to function and do your job and uh, be the woman that you were before. And by woman, I have to underscore that I mean female sex. So, but for the rest of the presentation, I'll just say woman for simplicity. So today, our, 1 second. I have no disclosures. Our objective is to understand the importance of the use of vaginal estrogen for women with genitourinary syndrome of menopause, to discuss the research data behind the effect of hormone therapy on cardiovascular health, to analyze the methodological limitations of the Women's Health Initiative, and explain the timing hypothesis and its clinical relevance to hormone therapy initiation. So if you're going to take away anything from this lecture today, I hope it's going to be the next 3 slides. If you will take something away and put it into clinical practice, I will have done my job. So I want to tell you about genitourinary syndrome of menopause. To the left of the screen, do you see my cursor?
we
Yeah.
do.
So to the left of the screen is what you would see in the anatomy of a premenopausal woman. Her ovary is nicely shaped. She's producing enough hormone. Her vaginal lining has excellent blood flow, and her vaginal lining thickness is nice. And there are nice rugae in the vagina, allowing for elasticity. But to the right is an ovary of a woman in menopause. The ovary is not producing enough estrogen. There is decreased blood flow to the vagina, resulting in a thinner wall and loss of rugae. and there is less secretion of fluid, um, making intercourse very painful, but also a predisposition to urinary tract infections that can, for many women later on in life, can lead to sepsis or hospitalizations and really increase mortality risk. So, and genitourinary syndrome of menopause does not just affect the vaginal area, it can actually lead to overactive bladder. Um, so, what do we do about this? I want you to know about vaginal estrogen. Vaginal estrogen is a very simple treatment solution, and it's very safe and it's not controversial. It can reduce the risk of recurrent urinary tract infection by at least 58%, which really is a preventive measure. Like we brush our teeth to prevent cavities, women post-menopause should be using vaginal estrogen to prevent urinary tract infections. The American Urological Association states that the indication for its use are recurrent UTIs, for genitourinary syndrome of menopause, for vaginal dryness, pain with sex, urinary urgency, and stress urinary incontinence. And I have found it to be extremely effective in a lot of this, really changing my patients' lives. And I'm not exaggerating when I say this. In terms of safety, many of my patients are worried about risk of stroke and heart attacks and breast cancers. And this is really because we had a black box warning on all estrogen products, regardless of route or formulation, stating that there's a risk of these complications. The black box warning was removed in November of 2025, but we're dealing with a marketing issue where we need patients to understand the safety of this product, the need for this product, and we also need physicians to understand how to prescribe it. So, additionally, ACOG states that for a woman with a history of breast
I'm sorry,
cancer,
the warning was removed for topical or for all?
for all actually, they for topical specifically, but for all they removed most of the risks there. Having said that, it's not that the risk is not there. They removed it as a black box warning, kind of stating that it as the number one concern. But for vaginal estrogen, it will not cause stroke, it will not cause breast cancer or MI because it just does not result in levels of estrogen above those expected to be seen in menopause. So, for a woman with a history of breast cancer, if non-hormonal treatments fail to treat vaginal dryness, then low-dose vaginal estrogen can be used. Contraindications are if a woman has a high-grade history of high-grade endometrial cancer, if she's bleeding and it's not clear what the source is, or where I'm cautious is where she has an estrogen receptor positive breast cancer, but is also on aromatase inhibitors. In that case, if you think about it, aromatase inhibitors are trying to bring the estrogen levels below that of what you see in menopause. So if vaginal estrogen will increase the estrogen levels to that seen in menopause, we're kind of working against the treatment. So that's where we need to get creative. And how to treat. So I'm not going to discuss all the formulations, but I'll talk about vaginal estrogen cream right now. So you can prescribe, just put in the EMR vaginal estrogen. They can take a gram daily for 2 weeks and then a gram twice a week. And what that equates to is really like the tip of the finger, like in the picture shown. Uh, Young or older women can take this. So if before I move on, I just want to say that this is really, really important to prevent urinary tract infections, to prevent sepsis, hospitalizations. It's very easy to prescribe and it's extremely safe. So now I would like to get to the core of my presentation, which is talking about systemic hormone therapy rather than local, which is what we just talked about, and its effect on cardiovascular health, which really is a topic that is, for lack of a better word, hairy because there's so much data. So, in terms of, the history of our understanding, is that in the late 1980s, everybody was excited about hormone therapy. There were 20 to 30 observational studies and meta-analyses that suggested that hormone therapy was beneficial for preventing coronary heart disease, dementia, mortality. It was like the miracle medication. This meta-analysis that I'm showing you showed a 44% reduction in coronary heart disease. And even the American College of Physicians advocated its use for preventive strategies. And so came the Nurses' Health Study, which was another large observational study for young women, about 121,000 women who were followed, given conjugated equine estrogen. If they had a uterus, they were also given medroxyprogesterone acetate. There were no formulations at the time, like estrogen patch, micronized progesterone, that did not exist at the time. So this is what they had to work with. And what they found in this observational study is a significant risk reduction of 49%. And so everybody was very excited about this finding. And then they said, as you know, observational studies show association, but they don't show causation because there could be confounding factors there. So they said, well, does hormone therapy actually reduce the risk of cardiovascular disease? And so we called for randomized controlled trials. And so the first one of these was, or one of many, was PEPI trial. Now, the trials that I'll talk about today are really landmark trials that I would want you to know about. So PEPI was one of them, postmenopausal estrogen progesterone intervention trial. It was a randomized, double-blinded, placebo-controlled trial. Only 875 women were involved. They were young, 45 to 64, or at least relative to the age of menopause. And there were several groups. Some were on estrogen alone if they had a hysterectomy. Some were on combined estrogen and progesterone. And what they found was an improvement in cardiac markers. So an increase in HDL, a decrease in LDL, lower fibrinogen levels. There was no effect on blood pressure. But this study was really too small and too short to detect differences in clinical cardiovascular outcomes. So we needed more information. And then came the HERS study, Heart and Estrogen Progesterone Replacement Study. This study was really done to assess secondary risk prevention. Cardiologists really like to do these studies because, patients who, for example, had a prior MI, it's much easier to find whether a medication is effective to see if it reduces recurrent risk in this population, and you need a smaller group. So this was easier to put together. So it was a randomized, double-blinded, placebo-controlled trial. There were over 2,000 women who were postmenopausal who were documented to have coronary heart disease, either if they had a prior MI or via coronary revascularization or angiographic evidence. So these women we know have a cardiac history. Mean age was 66 years old. Women were randomized to either combined estrogen and progesterone or placebo. And the primary endpoint here was non-fatal MI or coronary heart disease or death. So they followed these women for 4 years and extended this for another 7 years. So what did they find? They found that in the initial 4 years, there was no difference in the experimental versus the control group on the effect of coronary heart disease, or there was a non-statistically significant increased trend for death. Non-significantly reduced trend for non-fatal MI. And on extension, they found really no benefit there, with some improvement in lipid markers with LDL reduction. But what was very interesting about this study was that to the right, if you see, in the first year, these women were at almost double the risk of experiencing a cardiac event. And then later on, at year 2, 3, 4 is where we actually saw a reduced hazard ratio. So this study informed us of something that is an early hazard phenomenon. Basically, that there is early harm with hormone therapy initiation, possibly from the prothrombotic effect of hormone therapy, meaning there could be an increase in clotting factors and inflammation, and this can in turn, estrogen can destabilize plaques or cause thrombotic events in women with coronary vascular disease. And what this also showed us is that despite the favorable lipid changes, that didn't confer a reduction, a cardiovascular protection. So what we learned from this study, from the HERS study, is that hormone therapy should really not be used for secondary prevention of coronary heart disease. And then shortly after came the Women's Health Initiative. Notice I'm taking you through the history timeline of all these studies. So in comes this, great big Women's Health Initiative where it was probably the biggest study we have had, or I imagine will have, considering the limited funding for women's health. Here they enrolled 16,000 women who have a uterus and 10,000 plus women who had a hysterectomy. Women with a uterus, again, received estrogen plus progesterone. Women with a hysterectomy received only estrogen. And just to note the demographics, back then we didn't realize the importance of age at initiation of hormone therapy, but this study, the mean age of women was 63, and only 30% of the women were younger than age 60. And what the Women's Health Initiative showed, it scared everybody, really made women throw out their estrogen at that point, because in 2002, the estrogen plus progesterone arm was cut short by 3 years, because after 5 years, what they saw was an increased risk of pulmonary embolism, of stroke, of invasive breast cancer, and a non-statistically significant increased risk of MI and coronary heart disease. So everybody was shocked, scared, like that was the end. Doctors stopped prescribing hormone therapy. And that is really when we stopped learning about how to treat menopause. And shortly after, in 2004, 2 years later, the estrogen only arm was discontinued because an increased risk of stroke was noted, and no cardiac benefit seen. But I want to take a moment to look deeper in the data, because this is when the Women's Health Initiative was reanalyzed. The initial data was shared before it could be analyzed thoroughly. And when we talk about hazard ratios, and really that's what they looked at, if you think about an event being 1 in 10,000, but upon exposure to something, the event rate is 2 out of 10,000, that's a doubling rate of a hazard ratio that's double, which is kind of scary. But if you look at the absolute increased risk, it's minimal. 1 out of 10,000 to 2 out of 10,000 is quite small. So it paints a different picture. So in the Women's Health Initiative, the estrogen plus progesterone arm noted a not significant increase of 6 out of 10,000 cases of MI or coronary heart disease. For women who were younger than 60, there was a similar result. And what they did notice, though, is for women within 10 years of menopause on estrogen and progesterone, there was a non-significant reduction in risk. And on the estrogen alone arm, we saw a trend towards decrease in risk that was not significant. Similarly for women younger than 60 years old. But what was interesting is that they saw a reduction in MI, and I'm going to show you this data here, on extended follow-up at a 13-year follow-up. What they saw is that for women on estrogen alone, younger than 60, there was a 35% risk reduction in coronary heart disease, 40% risk reduction of MI, and a 33% risk reduction of CABG or PCI. And this was significant, statistically significant. What they also noted in red here is that women who were older than age 70 at initiation of hormone therapy had a significant increased risk of an MI. So what does this tell us? This tells us that age since menopause at hormone therapy initiation matters. There's an increase in coronary heart disease that reached significance for women over 20 years after menopause. And so, what are the takeaways from the Women's Health Initiative? I would say that one, there's a significant increase in risk if you're starting a woman 70 years or older. So, I would really highly question whether to do that. There was an overall not significant effect of hormone therapy on cardiovascular risk in most of the groups, with a trend towards increase or decreased risk, but the absolute change was not very big if you can't consider that it was about plus minus 6 out of 10,000. There was a significant decrease in MI, coronary heart disease, and CABG rate for women younger than 60 who were on the estrogen alone group, making you wonder, well, is there a benefit of estrogen alone and the progesterone causing some negative effect there? And for women within 10 years of menopause, there was a non-significant decrease in risk. And this is where the timing hypothesis comes in. And I think that this should really guide a lot of our decision making when we're looking at our patient and assessing whether they are or not good candidates for hormone therapy. Data shows that generally hormone therapy is beneficial or neutral if started within 10 years or before age 60, and it may be harmful or have neutral effects if initiated later. Granted, it needs to be done on an individualized basis because people have different cardiac statuses or health status, regardless of age, but there are trends. So, criticism for the WHI, it was likely underpowered for subgroup analyses. There were not enough women under age 60 to really understand the effect of hormone therapy for this younger population. We drew a lot of conclusions overall for these women who were 63, and this is not the age where most women come for help for treatment for menopause. Many participants were outside this window of opportunity, and the observational studies really included women who were started on hormone therapy near menopause, unlike the WHI. And finally, biology may differ later in life. So if you think about it, older atherosclerotic arteries may respond less to estrogen. Estrogen may cause coagulation activation, vascular remodeling, and it can really destabilize a plaque and cause rupture, which is what one is less likely to see for a younger woman. And remember this nurses' health study that we talked about earlier, where everybody was excited that there was a significant reduction in risk for younger women? Well, this was reanalyzed in 2008, where they tried to simulate what one would do in a randomized trial, where women were classified separately as initiators, so they were never on hormone therapy and they were started on it, versus non-initiators, meaning they were on it for a while, and these were women who were happy on hormone therapy, so they continued. And this allowed for capture of early events that were possibly missed by original analyses. And what they found is that there was no coronary heart disease benefit when capturing early events and a trend towards harm. There was an increased risk in the first 2 years. And if you recall, the Hearst study where they did the secondary prevention analysis, this is exactly what we saw there too, is that in the first year, there was an increase in risk, thereafter a reduction. So it seems like the effect of hormones, estrogen, on the risk of an event is greatest at the start and less as time goes on. So what observational studies might be capturing are health outcomes for women who tolerated the hormone therapy well and did not have an event, but likely left out women who were initiators. And this is exactly what the Nurses' Health study did well, is it tried to separate these groups of women. So, and I kind of talked about this, why the discrepancy in the results that we saw. It's the missed early events. It's the survival bias that current users were women who survived early high-risk period without events. So the reanalysis confirmed that observational studies overestimate cardiovascular benefit by missing early events. And when analyzed using methods to capture early risk, like randomized control trials would, the Nurses' Health Study showed no benefit, matching the results of the Women's Health Initiative. And if your head is not spinning yet from all of this information, in comes the Danish Osteoporosis Prevention Study, the DOPS trial. And what they looked, this was a randomized trial for young women who were age 50, 500 women in the experimental and 500 in the control. And what they found was a significant reduction of all-cause mortality, MI, and heart failure. However, this was a small sample size. Cardiovascular disease was a secondary endpoint, so number of events were small, and it was an open label design, so it wasn't blinded. So some limitations there. And so as we were learning more about from all of these studies, we thought, okay, so maybe there's not preventive benefit for women who are older, but maybe we could still find benefit for women who are within 10 years of menopause. Maybe we need to look at that subcategory and perhaps for a woman with clean vessels, giving her estrogen will be preventive. And this is what they did. They developed the KEEPS trial, the Kronos Early Estrogen Prevention Study. It was a randomized, double-blinded, placebo-controlled trial. It was a 4-year study, and they had 727 healthy women. These women were within 3 years of menopause and coronary artery calcium score less than 50. So really nobody could argue that these women had issues with their vessels. They were given either conjugated equine estrogen, oral, if they did not have a uterus, or they were all given, by then they had patches, estrogen patch, or a placebo. And women with a uterus were given micronized progesterone. Notice how now we're coming out with the current modern formulations that they used. And that was a big advantage of the study. So everybody was so excited to get to see these results. And when it came out, unfortunately, it showed no difference in carotid intimal medial thickness. A 14-year follow-up result showed no evidence of cardiovascular or metabolic benefit. Blood pressure, waist to hip ratio, fasting glucose, insulin, lipid profiles, no difference. So this was kind of shocking. And simultaneously, another study was trying to answer the same question. And that study was called the ELITE trial, early versus late intervention trial with estradiol. So they kind of looked at, tried to replicate the data that they saw in monkeys. They saw that there was a reduction in risk for monkeys who were within 6 years of menopause. I think they looked at, or later on, and so that's where that breakdown came. So they had a small number of women, 643. It was a 5-year trial. These were also young women. Group 1 was within 6 years of menopause, and group 2 was 10 or more years for menopause. So they were given oral estradiol, and they were given vaginal micronized progesterone for women who had a uterus. And what were the outcomes? Well, they did see for early postmenopausal group a 44% slower progression of subclinical atherosclerosis. So that was some good results there. But for women who were late postmenopause, meaning 10 or more years out, they showed no difference. And unfortunately, coronary artery calcium scores, total stenosis, and plaque did not differ. So what ELITE really showed is that there is benefit on a surrogate marker, the CIMT, but really no benefit for coronary atherosclerosis measures. No clinical event benefit was demonstrated. And so the interaction between timing and treatment effect was statistically significant, however. And so this was the interesting thing about this trial was that it was the first prospective randomized trial showing evidence supporting this timing hypothesis that I shared with you. So, uh, looking at all of this data, I want to take a step back. And what I was really confused about when putting this together is, well, why did the results diverge for observational studies? Remember when I said that, in the 1980s, everybody was so excited about these results. In fact, people were so optimistic about estrogen's ability to prevent cardiac events that when the HERS study was being together, that study when they were looking at secondary prevention, so for women who had an MI and what the effect would be on giving them estrogen, there were cardiologists who would even say, it is unethical for me to put them in the control group because I am almost sure this estrogen will prevent a recurrent event. That is the extent to which people were confident in the ability of estrogen to prevent cardiovascular disease. And shockingly, these randomized trials, especially the Women's Health Initiative trial, showed very different outcomes. And why did these results diverge? Well, first of all, and we touched on this a little bit, is confounding. The hormone therapy users differ from non-users in their demographics. Women who are in hormone therapy, we find, are statistically more likely to be of a higher socioeconomic class, to be more educated, to have healthier behaviors. So it's a matter of access, I would say, access to care. And so there was a healthy user bias. Women who had more access and knowledge about these treatments were probably more likely to take hormone therapy, but also have good lifestyle habits and more. There was a lack of blinding in observational studies, so it is possible that there was an underreporting of symptoms possibly due to perceived benefit. Placebo is very effective. It can contribute to a large percentage of the efficacy of medication, I think as high as 30%. There's a survivor bias, which we talked about, where observational studies, when they collect people or basically invite people to join the study, these are people who are already on hormone therapy for several years. People who had complications from hormone therapy likely wouldn't have stayed on them and wouldn't have enrolled in the trial. So you're likely seeing people enrolled who did well on these medications and missing women with early adverse events. And so their results were missed. And there's a time-dependent risk. The Women's Health Initiative showed elevated coronary heart disease risk in the first 1 to 2 years of initiation, but then there was an attenuation thereafter. So we're seeing results for women with a mean age of 63, more than 10 years out from menopause. So the key insights from all of this is that observational studies enroll few recent initiators, and most of the data reflects long-term users who are past the early high-risk window, while trials efficiently capture early events because these people are randomized. Women can't choose which group they're in, so we have more reliable data. So observational studies systematically overestimated cardiovascular benefit by missing early events and capturing only survivors of the initial high-risk period. And to look at meta-analyses and compilation of data for women within 10 years of menopause or younger than 60, here you'll see that these meta-analyses are showing a significant risk reduction in coronary heart disease for these women, as well as a reduction in mortality. So the question is, there still could be something there. And if you recall, we did see a significant reduction in risk for women on conjugated equine estrogen alone. Yet this was not seen for the same group of women who were given medroxyprogesterone. Is medroxyprogesterone counteracting that benefit? Maybe. Right now, we seldom use it. So it would be very interesting to see what the effect would be of starting younger women on estradiol, especially patches, rather than oral, because patches don't increase clotting factors, and micronized progesterone, which is more identical or closer to what the progesterone we produced, which is not thought to be as have as many side effects as the medroxyprogesterone. And it would be interesting to see what those outcomes would look like. But the meta-analyses are still showing some promise for these younger women. And to briefly comment, the recent 2025 Cochrane review looked at 24 studies with 45,000 participants, and it showed that combined hormone therapy probably makes little to no difference to coronary events, and estrogen-only therapy probably makes little to no difference to coronary events either. And so, as you can see, when I started saying that the data here is complicated, this is why it's complicated. We do need further research. The timing hypothesis rests primarily on post hoc subgroup analyses rather than prospectively designed trials. And this is really what we need. We need a randomized controlled trial to prospectively evaluate effective timing of hormone therapy initiation relative to onset of menopause. And although risk reduction for women less than 10 years from menopause was statistically significant, there were only 42 coronary heart disease cases and 35 MI events in the conjugated equine estrogen group over 13 years. So as you can see, this event is more rare in these younger women, but also we don't have large enough numbers to draw any strong conclusions. And so multiplicity of outcomes and subgroup comparisons do limit the strength of the findings. So to summarize this, I shared a lot of information, and I definitely wouldn't expect you to easily kind of formulate this in your mind, hearing it in this format. It took me a while to process it myself, but this slide is just a generalist summary of how I understand hormone therapy and cardiovascular disease. So I would say, number one, time of initiation of hormone therapy since menopause really matters. Look at your patient, what is her age? How more importantly, how far is she from menopause? Because if she went into menopause at 55, which can happen, and let's say she comes in and she's 63, she's within 10 years of menopause. But if so there's a factor there, and she might be a great candidate. So we know that hormone therapy started within 10 years of menopause may have cardiovascular risk reduction, particularly with estrogen alone, and a protective or neutral effect for estrogen plus progestin formulations. Number three, hormone therapy started more than 20 years after menopause can increase risk of coronary vascular disease. So if you have a woman coming in her 70s who's having hot flashes, maybe hormone therapy won't be the best thing. But the nice thing is that we have non-hormonal formulations like Veoza, which works beautifully for hot flashes and can really support their quality of life without putting them at a risk of a heart attack or destabilizing their plaque. It is important to know also that severe hot flashes seem to be associated with a greater cardiovascular risk. We don't fully understand why. It's not that the hot flashes cause the heart attacks or treating the hot flashes reduces that risk, but there is a strong association. So if a woman starts having hot flashes early on and it's severe and for a long time, consider that another vital sign for the fact that she might be at increased risk of a cardiac events, and perhaps she needs a better preventive workup. Finally, and most importantly, and this is really to respond to this social media frenzy that we're in now, where menopause became such a big business, where there are so many people trying to sell hormones to women, kind of like in the 1980s, they're selling it as this magic bullet. You need to know and tell your patients that hormone therapy should not be used for primary or secondary cardiovascular disease prevention. It can be a welcomed side effect of treatment for the appropriate candidate, but it should not be used for that intent. And at this point, I want to look at other aspects of what really affects women's cardiac health, because I think that a lot of people in excitement for hormone therapy are getting tunnel vision, thinking that, and especially patients, that if they don't get hormone therapy, they will not be healthy. And that is just one factor of many. And so reminding patients and reminding ourselves that addressing obesity, addressing smoking, diabetes control for all of us endocrinologists here, these are crucial as affecting their, addressing cardiac health, reminding your patients to exercise, addressing the high blood pressure, the mental health, and remembering that for women, there are female-specific risk factors that don't apply to men. And these are, I would delve into, whether or not they had preeclampsia or preterm delivery. These are female-specific markers for an increased risk of cardiac events, because pregnancy is a kind of like a cardiac stress test for a woman. Furthermore, low estrogen states are a risk. Like if a woman has early menopause, that is high risk, increases the risk. If they have autoimmune disease, if they had breast cancer treatments. And this is a little chart that I made myself. It looks at, I don't want you to take it fully at face value. This is an approximate comparison of what is the cardiovascular risk reduction from lifestyle interventions versus hormone therapy. And I kind of, knowing, yes, that I looked at what is the typical risk reduction for different lifestyle interventions as compared to approximate risk reduction from hormone therapy. And if you look here, multiple healthy lifestyle factors can have a more than 70% risk reduction. Smoking cessation, more than 50% risk reduction. Physical activity, 150 minutes per week, more than 25% risk reduction. High quality diet, also benefit. And in comparison to that, and these shouldn't be looked at as direct comparisons, even though I put them next to each other, because this was never studied, in a formal, research study where they looked at outcomes. But I did do the faulty thing of putting them next to each other. So for hormone therapy, for women on estrogen alone who are within 10 years of menopause, or actually women less than 60, the risk reduction is a little over 25%, the relative risk. For women who are on estrogen plus progesterone in that same age group, there is null benefit. And for women who are more than 70 years old or more than 20 years post-menopause, there's actually an increase in risk. So, while obviously this chart can be debated, the whole takeaway here is that do not forget about lifestyle medicine, that we have very strong, good data on these very simple prescriptions that should not be taken for granted. And lifestyle will help a woman at any age, whereas hormone therapy will, if it's helpful, will be likely more helpful if started within 10 years of menopause, and later on, in terms of cardiovascular benefit, we could see neutral to possibly even increased risk. And finally, the top 5 modifiable risk factors for cardiovascular disease, 57.2% cases of the events are attributed to obesity, which we as endocrinologists treat, high blood pressure, high cholesterol, smoking, and diabetes. So as you could see, preventive care is in our hands as endocrinologists. Every time you see a patient, we can make an impact. And so these are my references. I'm not going to go